right, can everyone please take their seats? And we'll get started with session 4. All right. So I hope you all had a good lunch, and I hope you got a chance to see the innovation showcase. If not, it's still going on this afternoon, so I highly encourage you to take a look at it when you go for the coffee break this afternoon. It's always difficult to do a panel after lunch, but this one is a real treat because you will be hearing from several countries that have really prioritized universal health coverage, and particularly with an emphasis on the most vulnerable people in their populations. So without further ado, I would like to turn things over to Patrick Ndumbanzi, the Minister of State in charge of Public Health and Primary Health Care in Rwanda.
Thank you. Thank you for the kind introduction. It's an honor for me and a pleasure to be moderating this session. Excellencies, ladies and gentlemen, good afternoon. Please don't fall asleep. Thank you, everybody, for being here at this Universal Health Coverage Forum, and specifically at this session, the first sessions where we'll be talking about accelerating UHC progress and learning from countries' experiences. As you all know, there's no single path to reaching universal health coverage. Different governmental, governance, organizational, and financial arrangement may contribute to the universal health coverage goals. So this afternoon, we are privileged to have 4 exceptional panelists who have willingly accepted to share their experiences from their countries in implementing some of the UHC interventions. So they will be talking about the policy and the guidelines that they've changed, that they've put in place, that are working. They'll be talking about the reforms that were conducted in various areas and the engagement of different stakeholders, government, non-government, non-state agents. So a quick introduction. I will start from my immediate right. We have Mohamed Musa, who's the Executive Director of the Bangladesh Rural Advancement Committee. It's somebody who has extensive experience. He has worked all over the world. He will be sharing some of his experience, especially about the changes that happen, because he's a specialist in managing changes. And just after him, we have the Honorable Hamajan Nahim, who is the Deputy Minister of Policy and Planning at the Ministry of Public Health of the Islamic Republic of Afghanistan. Hamajan is a medical doctor, but with also a very wide experience with NGO, government entities, non-government, internationals, and he has been with the Ministry of Health for quite a while. And just next to him, we have Honorable Cleopa Mailu, who's the Cabinet Secretary of Health in Kenya. He's also a physician by training and did genetics after that. And he has been working in the health sector for quite some time as well. Last but not the least, we have Honorable Lampin Min, who's the Senior Minister of State for Health and Transport for Singapore. So please welcome them. Thank you. Thank you. And thank you, Excellencies, for making the time to come to this conference and for accepting to share some of the experiences from your country. The world is eager to learn, and this is the platform that we've been provided to. Without any delay, as we are saying, we're going to start the session by asking Dr. Cleopa Mailu to tell us a little bit about the changes that happen in Kenya, what they've done differently, what they have learned over the years, and what are the challenges that they can share with all of us. Please, Dr. Cleopa.
Thank you. Thank you, moderator and colleagues. I think in Kenya, I'm going to talk about three aspects of our universal health coverage. And I want to begin by talking about the policy changes which were effected in 2013, 2014, because the issue of access of healthcare to Kenyans has been on the table for some time. And there were factors which hindered people from seeking healthcare or ensuring that they do not receive the care they need at the time they need it. And therefore, the government then did several things. One, they recognized that investing in maternal and child health was very crucial. And therefore, they introduced free maternity for all pregnant mothers to be able to deliver and access care without a fee for service. They also made a policy pronouncement that under fives are going to access free treatment within our facilities, and that meant immunization and other activities were going to be accessed by that population. We also abolished user fees for anybody at accessing primary health care level, that is at the dispensary health center level, so that Kenyans could be able to go to those primary health care facilities and receive services. On top of that, the government introduced a subsidy program where they bought insurance for the orphans, they bought insurance for the indigents, and they bought insurance for the physically disabled, those who are challenged, so that they could access care within our facilities. So those groups were given that opportunity to be able to access care. This was in preparation of making sure that you do not fail to attend a facility because of user fees, because we know out-of-pocket expenditure, catastrophic expenditure was affecting those populations. Therefore, the focus was on maternal child health, the elderly, the indigents, and the orphaned. Now, as we moved on, government realized that those policies are good, but there were services which were missing within our facilities. And if the government waited for budgetary allocation to be adequate enough to purchase equipment or to equip those facilities or to bring those services to the people, it was going to take many, many years. And therefore, a policy decision was made to partner with private organizations or private companies to be able to have a framework of managed equipment scheme to equip 98 hospitals across the country with various facilities, that is radiological, ICUs, CSSDs, renal dialysis equipment, and also theater equipment. This meant that we bring forward consumption of services which were to cost 38 billion yens, or 38 billion Kenya shillings, to Kenyans upfront. And therefore, that partnership with the private sector meant that people could access renal dialysis in 47 hospitals, or 49 hospitals as opposed to 2 previously. They could access MRIs, they could access radiological investigations, mammography, ultrasound, and they could access theater because every hospital was renovated to provide theater services in 2 theaters. Therefore, that partnership has given us a framework of engaging as we move forward with the private sector to be able to bring services closer to the people and in advance of our budget. And therefore, what we are doing as a government through that experience, we have learned as part of access of both primary and tertiary care, you can partner with private institutions to be able to do so. That is addressing that aspect. The insurance model was to ensure no financial impediment was in place of Kenya, it was in front of Kenyans not to access care because they are poor or they cannot afford. Now, moving forward, we have made a pronouncement that we want to attain universal health coverage in the next 5 years. And government has made a deliberate policy change, whereby in our population, the 1.5 million Kenyans who are indigents are going to receive insurance. The 1.8 million Kenyans who are 70 years plus are going to receive insurance. And therefore, we reform our National Hospital Insurance Fund, which is a government-sponsored fund to be able to, at the end of 2022, to put insurance cover in the pocket of Kenyans, because we believe that Kenyans should be able to consume services both in public and also in the private institutions, and making sure that we convert all the aspects which we have been putting in place in the last 4 years into an insurance scheme. Then we can ensure that Kenyans do receive services wherever they are. Of course, we are going to be engaged in capacity building. The spread of the facilities has to be built, and also focusing on non-communicable diseases, which are also an issue in our country. Thank you.
Thank you very much, Honorable Kalliopi. And thank you for sharing these insights about access to care, primary and tertiary care through PPP, and also removing financial barriers to care access, as well as what Kenya is intending to do next. We're going to go round. Each panelist will have 5 to 6 minutes. I'm going to go next to Honorable Ahmad from Afghanistan. And we all know that it's getting alignment of different stakeholders in a program as complex as universal health coverage is one of the major issues. Alignment and streamlining activities. The questions that we have for you are about how did you get to involve other players in facilitating access. We would like to know more specifically the role of all the other actors that have contributing to increase or facilitate access to care in Afghanistan. Please share the lessons that you've been learning.
Thank you very much, Your Excellency and Excellencies, ladies and gentlemen. Good afternoon. Afghanistan is a country which is in conflict for almost 4 decades. We have a population of 30 million. There are many refugees in the neighboring countries, and at the same time, we have internal displacement due to conflict. The life expectancy is 62 years, and total fertility rate is 0.1, infant mortality 45 for 1,000 live births, and under 5 mortality 55 per 1,000 live births, and similarly maternal mortality is around 690 per 100,000 live births. In 2002, following the fall of the Taliban, the Ministry of Public Health started from the scratch, and the Ministry of Public Health made very bold decisions in reforming the health sector, and there we made a decision, first of all, to define a basic package of health services for the country. And this basic package of health services, the key elements and criteria that were used, it should be intervention that has the greatest impact. It is cost effective and to address the problems of many people, and at the same time, services should be, everybody should have equal access. And for this, a standardized package was developed, and redistribution of the health facilities to ensure equitable access, especially for the underserved areas in rural Afghanistan. And similarly, in 2005, the Ministry of Public Health, to complement the basic package of health services, decided on an essential package of hospital services. The second decision that was made was that the government did not have the necessary capacity to expand the services all over the country. So therefore, counting on the strength of the non-governmental organizations, we made a decision that we will contract out service delivery to the non-governmental organizations because of their strength in the years of conflict, and the ministry would serve as steward of the services where we will finance health service delivery, where we will do monitoring and evaluation, collect information, and at the same time provide guidance, develop policies. That's what we did. So contracting in Afghanistan, as I explained, the ministry started service delivery through NGOs, and then we took the responsibility for the stewardship. Why we did that, then we had, purchasing for value, and that was efficiency, access to services by the population, and taking care of the quality, and to improve equity, and then monitoring. The advantages were, of course, tremendous. The NGOs were much flexible in the management of the service delivery, and we avoided, the government bureaucracy. At the same time, we also thought, that it will reduce corruption, because once through a very transparent process, that's through bidding, select, the best NGOs and award them contracts. They had the autonomy, and then also the transfer of knowledge and skills was happening through non-governmental organization with the provincial offices. And government, of course, then there was plenty of time for them to develop policy strategies and the necessary protocols and guidelines. Limitations were also there, and because of they were they could be more expensive, but when we did a study, that we found out that there was not much difference, and sustainability is an issue. Usually there are concerns, but as long as we have the resources properly, it's mainly Afghans that are employed by non-governmental organizations, and then the non-governmental organizations had the responsibility of management and the staffing, procurement of supplies, building capacity, service delivery, and they had to account for all. We chose or selected a number of indicators, and they were given targets, and based on that they were supposed to deliver, and they were held accountable. There was both remuneration for good performance, and at the same time, if they did not perform, contracts were terminated. Achievement so far is, the infant mortality in 2002, it was 165 per 1,000 live births, while in 2015 it is 45. Similarly, for under 5 mortality, it reduced from 257 to 55 for 1,000 live births, and similarly for maternal mortality. And TB treatment rate, with the global average, for low and middle income countries is 80, but our achievement was 87% success rate. So there's a lot of progress that we made. So what I'm trying to say is that probably universal health coverage, we can have progress even in conflict situation, but unfortunately what I noticed that there is very little said about the countries which are in conflict, and I would like to thank all the donors that are supporting Afghanistan and its effort to achieve universal health coverage in spite of the challenges that are there. I'm sorry, my time is up, so I cannot continue to tell you more. Thank you.
Thank you, Honorable Minister. You get time to continue on your remarks. We will give you a second round. But thank you very much for sharing how you've contracted services and bringing in the notion of paying or purchasing health, bringing in the notion of value for money, bringing in the notion of stewardship that government has and the monitoring and evaluation role that you have, and it offers me a good transition to go to Dr. Musa to ask a little bit more about how the partnership is managed and how the accountability is ensured. Please.
Good afternoon. Thank you, Honorable Moderator and Excellencies. At the outset, let me make a couple of comments, if I may. As I was looking into the topic of this afternoon's conversation of accelerating universal health coverage, and I was feeling that looking into our panel, and with due respect to all of our panelists, I was feeling we don't have any women in our panel. And I was feeling, well, we are talking about leaving no one behind, and we are missing the voices of one of the most important group in this particular panel. And how would we really have that coverage? So I apologize to begin with. Second comment is that when I was preparing last night, that what therefore I want to possibly share based on yesterday's conversation, that has changed in this morning because I listened to everything of this morning. I thought during lunch, let me rather focus on 2 points that may a little bit add value to the further, to deepen issues further as we discussed in the first half of the day. And those 2 points I'll be discussing is taking the discussion on community involvement or engagement, or involvement of the patients and engagement and getting their voices in the system, to the whole issue of accountability. Because I don't think that just engagement and participation is enough unless communities and people have mechanisms to hold duty bearers accountable at every level. So I'll elaborate a little bit on that based on the experience that we had. Second thing I'll focus on is this whole issue of partnership, because that was also discussed just before lunch break, that what are the different modalities of partnership, especially as our vision for universal health coverage, while it's same, we do find that different countries and in different timelines, you will find differences in context, so you need to adjust the modality of partnership, and I can share some of the experience on that. On the first one, as I was talking about accountability, since I represent a civil society organization, BRAC, and many of our partners, we work together in 11 different countries, including Bangladesh, where we originated. Holding duty bearers accountable for universal health coverage with quality services has 2 elements, as we found out. Of course, the element of strengthening services, making sure that the quality of service is good, as well as making sure that accessibility is high, equitable service is there. So we work with service providers a lot, either directly with your staff or with partners like private sector partners on government. And then work with communities, because communities are not necessarily ready to hold duty bearers accountable. So therefore, how do we really organize communities? How do we give them the tools, techniques, methodologies, and the power to hold duty bearers accountable? And in that, various things have evolved over time. We know this whole social scorecard, that we know that how do we really use this scorecard at the community level to really have negotiated discussion with the service provider so that service can come in. We know that how to organize communities. Like in BRAC, we worked in the health program to improve the capacity of health workers through even technologies like mHealth that is working now in urban areas, to community empowerment program where you organize community into collectives so that they have the voices in the local governing bodies. And you can do that at that level. Challenge starts when you go above that, because accountability does not stand only at the community level. You cannot ensure accountability just by working at the community level. In order to have accountability, you need to go above community level, from engagement and community level accountability to managerial accountability at the district level, for example, where management needs to work on various things, not only systems, but also issues like corruptions in the system, to go above to the national level, where it becomes more difficult because then accountability is driven by many other factors, including political factors. But it becomes even more difficult when you go above national level, because over there geopolitics play a role. And we know in many situations, it's not only the services at the field level, but also the causes behind ill health, causes behind challenges that health problems faced by the people are often lies at every level of the global system. And if we cannot hold these global systems accountable at every level, if we reward rather some of the global systems issues, especially in places where people get displaced and then suffer from health challenges, and you have no mechanism of holding that accountability at the multiple level, then you basically have the problem. So that's one of the things. Second thing I would say is this whole issue of partnership modality. On the partnership modality, you have to vary from area to area, time to time. For example, in BRAC, when we ran oral dehydration therapy program back in 70s, our state was not able to deliver services. So BRAC employed 100,000 staff directly to go to home to deliver services. But later on, 20 years down the road, when we worked on immunization program with the government, then we realized that situation changed. So you work in partnership with government and build their capacity, you mobilize communities, government immunize, and you partner together. So with time it changes. As we now work in 11 countries, as time goes, you see with time to time, in different countries, your different situation is there. How do we identify what kind of modality of partnership would work appropriately in what situation is something that requires tool, techniques, methodologies to understand that situation and calibrate your interventions accordingly. And if you cannot do that, then you may end up doing something that is incompatible. Thank you very much.
Thank you, Dr. Musa, and thank you for your concluding remarks where you say that situation changes. You need to adjust, you need to calibrate, you need to recalibrate. Is the transition to Honorable Minister Lam, for whom I would like to ask, with all this epidemiologic transition, with all these things that happen in the society we live in, how does a health system adjust continuously to be able to meet the UHC? We all know that nothing stands still, especially in these times where everything is moving so fast. It seems that UHC is a moving target. We would like to know how we innovate to scale better quality care and efficiency services delivery to address upcoming challenges such as aging and rising population expectation. Please.
Thank you very much, Patrick. First of all, let me just thank Japan as well as the organizing partners for organizing this very useful forum. I find that a forum like this are very useful for us because we can learn from one another's experience. Some people may ask, Singapore is a very small country. Whatever we do in Singapore may not be applicable to other countries. And whatever policies or suggestions may not be able to implement in your own country. But I thought that through all this sharing, we are able to learn some of the principles behind the policies. At the same time, we also learn from one another's mistakes so that we do not commit the same mistake like what ex-minister Shiozaki mentioned in the session this morning. And through these sessions, I think it can be very useful for those of us who attend this. So yesterday, at one of the breakout sessions, I shared with some of the participants about how we're going to cope with the aging population. And I thought that it would be quite good for me to share Singapore's experience in our healthcare transformation, not just to cope with the aging population, but also to manage rising healthcare costs. Because we have been talking so much about putting in more resources, doing more, but with an aging population, the healthcare costs will definitely rise. And we want to make sure that whatever we do can be sustainable in the long run. Or else I think we will end up raising taxes, making healthcare not so affordable. Singapore started many years ago as a third world country, and of course during that time we are quite concerned about infectious diseases, communicable diseases, child maternal health. But with time, with a better healthcare system, and also with a continuous transformation of our healthcare system, we are looking at different aspects. In fact, at the beginning of this decade, we have this Vision 2020, Healthcare 2020, where we look into the quality, the accessibility, and affordability of healthcare. And I'm glad to say that we've managed to do much to address some of these concerns. And moving forward, we are actually looking at beyond 2030. What is Singapore going to do to address some of the challenges beyond 2030? And if you have a background of the demographic in Singapore, right now we have about 12 to 13% of the population above the age of 65, all right? And this will increase to 1 in 4, about 25% when we reach 2030. And this is actually attributed to two main factors. One, which is the low total fertility rate in Singapore. Right now, our TFR stands at a low of 1.2. We can hardly reproduce to replace ourselves. Secondly, Singaporeans are also living longer. Our life expectancy for women is 84, and for the male is 80. So with these two twin jeopardy, is a perfect condition, perfect storm to create a rapidly aging population. So in the next 10 to 13 years, our population who are above the age of 60 will actually double from 12.5% to 25%. And this thought can be quite daunting if nothing is done about it. So to address this shift in our demographic changes, our ministry has actually come up with a new vision, not just the Vision 2020, but now we have three key thrusts, what we call the Beyond 2030. The shift from healthcare to health. Basically, what we are trying to do is not just providing quality healthcare, but to also promote preventive medicine as well as health promotion. So the shift from healthcare to health, all right? Secondly, we're also shifting from quality to value. So it's not just about bringing in the state-of-the-art technology, doing more, but to look at cost effectiveness and what is the most appropriate for the patient. And third is actually the shift from hospital to community. And this is actually one key area that I wanted to share, which is the transformation of our primary healthcare. And I think like one of the speakers who said yesterday, without primary healthcare, no PHC, no UHC. So primary healthcare transformation is one area that we are seriously looking into. We have done a lot. We have tried to bring in the private sector, the private GPs, and together with the polyclinics who are looking after the public sector side, we are trying to make sure that we can provide good quality primary healthcare and to anchor the patients at the primary healthcare level without the need to escalate unnecessarily to the secondary healthcare and tertiary healthcare. I understand my time is running out. I have a lot to share, but I think during the question and answer, I'll be willing to give you details about our primary healthcare transformation and what we have been doing to address some of these issues. Thank you.
Thank you very much for this insightful remarks where we talk about moving from healthcare to health, moving from quality to value, moving from hospital to community, and getting back to primary healthcare. So you are cycling back where we are starting, and the focus is still on primary healthcare, which means that in developed country, in less developed country, that's where we should put all our efforts and energy, because it speaks to something that's bigger. It speaks to sustainability. There is no universal health coverage without being to sustain it. So universal health coverage makes only sense if it lasts. It cannot happen a year, it can happen 2 years, but if it's not lasting, we haven't reached it. So now, at this juncture, we want to open it up to the audience, to wake them up a little bit. We will take 5 questions, and please, when you get the microphone, identify yourself and tell us to whom the question is directed. the panelists will get the time to respond to your questions, and after that they will have final, if we have time, they will have time to do final remarks. So we start back there, and then Patricia. Yes, please.
Okay, so first of all, thank you very much for the wonderful presentation and sharing your knowledge and experiences. I'm Dr. Tobe, a senior advisor from the Japan International Cooperation Agency, JICA. And I have a question specifically to the representative of Singapore and Kenya. It's all about the primary health care. So you mentioned that in Singapore, currently you are shifting the priority to the primary health care. But I think that there will be several the positive or negative responses from the other medical community, health providers, or even among the public, maybe or some politician. Even though the primary health care is majority are very cost effective, but many politicians or even the patient may prefer to have a fancy the state of the art the technology rather than preventions or some very primary care. And also in Kenya, you are also introducing some some advanced technology, but I understand that in Kenya still there's a lot of the population who don't have enough access to the primary health care. So how do you think that what is the best mix or the balance between the resource allocation distribution between the primary health care and such advanced technology? Thank you.
Thank you. Patricia?
Yes, good afternoon, colleagues. First of all, many thanks for the excellent remarks by all the panelists. My question is directed to the representative from Singapore, Mr. Lam Pin Min. I think that his presentation brought to the table perhaps the challenge that all of us are facing in pushing forward the universal healthcare agenda, and that is how to bring health into universal health coverage. And you eloquently described how you are approaching the challenges that you are facing in Singapore. So in a way, you create the conditions to make the priority of developing healthy populations or trying to push the healthy life expectancy agenda. So within that context, and I think that's highly relevant for other countries that perhaps are not going through the demographic transitions that you are going, but one always can learn and anticipate the future, especially taking into account that as a result of the mortality gains, reductions, all the countries are starting to get older. So my question is, specifically, in order to advance the healthy life expectancy agenda in Singapore, what are the key policies that you are promoting, and how are you funding that, both at the community level, at the workplace level, as well as at the national level, so they are sustained? Thanks.
Thank you. Please.
Thank you very much. Susan Brown from Gavi, the Vaccine Alliance. Thank you to all the panelists for some very interesting experiences to share with us. A special thank you to Mohammed Musa for his timely observation that it's important to leave no one behind. I'm curious to know, with the advent of the Sustainable Development Goals, how you're thinking about those at country level in terms of universal health coverage. How are you using or thinking about using the momentum behind the Sustainable Development Goals for implementation of universal health coverage? Thank you.
Thank you. One last question.
Thank you very much. I'm Chika Saito from Malaria Nomo, Japan. And my question is to Mr. Musa. And about the role of community, I think the community is also going to play an important role of monitoring, because they are the ones who knows about the most needed population, who are not even included in the official statistics. So how do you think about that to ensure that the community can play the role to ensure that no one is left behind in terms of the monitoring?
Thank you. Maybe let's respond to these questions. The first question by Dr. Tobe. The Honorable Minister Lam, if you could start.
Okay, allow me to just address our Japanese colleagues' concern about having to actually move from tertiary, secondary healthcare and now concentrating on primary healthcare. And this is actually one area that many developed countries are currently facing. I think when we started building up our healthcare system, we have been spending a lot of resources in building the best hospitals, the best specialist center that you can have with state-of-the-art technology for treatment of all kinds of diseases. In fact, this is the phase that Singapore has also gone through. And one of the things that we may have neglected in the past is to build on primary health care. I think many countries, including Japan, Hong Kong, Taiwan, we are facing the same kind of challenges, which is why there is a lot of emphasis right now to transform our primary healthcare system. And to transform our primary healthcare system is not just about convincing the healthcare givers. We need to convince the patients themselves, because the patients have been so used to easy accessibility to specialist clinics and specialist treatment. The moment they have a headache, they will just go to see the neurologist because it's just 5-10 minutes drive away. If they have a tummy ache, they will see the gastroenterologist. And we feel that this is not a very effective use of resources. And therefore, we need to convince patients that the right thing to do is to stick and anchor yourself to a family physician. I'm glad you asked this question because I didn't have time to elaborate on our transformation. What happens is that in Singapore, our primary health care is primarily provided by the private general practitioners. 80% of primary health care is provided by the private sector. Only 20% is provided by the public healthcare sector. And we want to harness the manpower as well as the expertise of the private GP to come together so that we can work as one primary healthcare system. And in order to do that, we are forming team-based care, meaning to say, for example, in the public sector, in the polyclinic, we are increasingly forming teams of doctors, nurses, nurse counselor, as well as case coordinator, so that they can provide a holistic approach to managing a patient. But for the private GPs, many of them are very fragmented in the sense they are in their own solo practice, doing their own things in silo. And what we have done recently is to form a virtual primary care network, what we call PCN, where we gather like-minded general practitioners, about 15 to 20 of them, come together to form a virtual network whereby the government will then provide some resources in terms of funding to support them in their work, such as providing diabetic retinopathy photography services, podiatrist limb assessment, even nurse counseling as well as dietitian counseling, so that they have economy of scales. And at the same time, the PCN doctors can also share resources and share experiences so that they can learn from one another, right? And by doing this, we are actually leveling up the practice of the private general practitioners so that patients can have better confidence in them. And we're also thinking about how to anchor these patients at the primary care level. And this can be done by empanelment, subsidies, something that we are constantly looking at. On the part about universal health coverage, I think the two main issues that we do look into, one is accessibility, and second is affordability. And in our financial framework, we have what we call a 3M system. The first M stands for MediSave, which is a compulsory savings, medical savings for every citizen. So every citizens who are working will have to contribute a certain amount of money into their own MediSave account to be locked up only for rainy day use for medical conditions. And secondly, the second M is actually our universal health insurance plan, what we call MediShield Life, where every citizen will be mandated to participate in this universal healthcare coverage. And the third M stands for MediFund, which is a government endowment fund to assist those people of low-income families, so that in the event that they find it difficult to afford a particular medical treatment, the MediFund can be used so that no one is denied of any medical treatment in Singapore just because they cannot afford it. And of course, we get the community involved, we have workplace health programs to keep our population healthy, eat healthily, as well as to promote exercise. And of course, most importantly, at the national level, we have subsidy schemes, to make sure that the healthcare is affordable.
Thank you very much. When you're still having the microphone, there was a question that was asked by Patricio, who asked about health promotion, prevention. What do you do to ensure that you have a healthy aging population? I think that was the question. If you could say, what are the real intervention that you implement to ensure, what type of promotion do you do, what type of messaging do you have? Because it's one thing to build the system, but it's another thing also to empower the community to have those behavior changes that will ensure that in the future they don't get sick.
Is this directed at me? Oh, okay. Okay. All right. In Singapore, we have this action plan for successful aging. As you know, like I've mentioned in the past, we are a rapidly aging population. We're very concerned. In the past, we used to call this the silver tsunami phenomenon. Everybody is looking at the tsunami that's coming. But we have tried to change the conversation from a silver tsunami to a longevity opportunity, productivity. So with longer lives, that will provide more opportunities, not only to continue working, but also to actively engage as well as contribute to the community. So we do have this action plan for successful aging, where we try to make our seniors as healthy as possible, to continue to engage with the community, both at different levels, at the personal level, community level, as well as at the national level. And in addition to that, I think we have also recently enhanced our health screening program for the populace. It's called Screening for Life, SFL. We have increased more subsidy for health screening to the extent that the normal population who are eligible for this, depending on the age, only need to pay 5 Singapore dollars for a whole host of health screening that covers diabetic screening, to cervical cancer screening, to colorectal cancer screening. And if you are of the low-income family, you only need to pay 2 Singapore dollars for the entire panel of tests. And if you are of the pioneer generation, what we call the very senior pioneer generation, it's totally free of charge. All right.
Thank you, Doctor. We need to move fast because we are running out of time. I would like to ask Dr. Cleopa to provide some comments about the right mix between primary and tertiary care in Kenya. Thank you.
Thank you. I think I would like to respond to 2 issues. One, of course, like any other country, at the time of healthcare, we concentrated on tertiary institutions, at the expense of primary health care and other institutions at the lower level, and later realized that is the drive, which is very important. That is not unique to Kenya, it's unique to many countries, and now we have to reverse that to be able to concentrate on primary health care. But let me say Kenya is unique, and somebody mentioned that every country is unique, and the pathway to universal health coverage is not going to be the same. Kenya in 2010, the country voted for a constitution which devolved health services, and this was implemented in 2013. Therefore, the task of providing health services is vested upon the lower tier of government, that is the county governments. And the national level, we are policy to drive the policy standards and the quality of care which we are going to provide. When I said that, I mentioned that the government made certain policy changes. The agreement was going together with conditional grants. We became purchasers of services for those particular groups at the county level. So we reimburse counties for the women who deliver, for the children who get vaccination, for the people who access care without paying user fees. We created conditional grants to give to the counties so that they can improve those services. When we introduced the managed equipment scheme, of course, we realized that there were disparities across the country in terms of health facilities and the level of care which they could give. Now, with a devolved system where you are not moving from one county to the other, we introduced these schemes to be able to bring us kind of equity within the counties, equip institutions, bring certain facilities at certain counties where they were not available because they could access them elsewhere based on the earlier system of government. And therefore, we are unique in a way that now community participation is percolating to the grassroots, because at the county level, even budgeting process, communities are involved, and therefore they have a voice in what services they are going to receive as we dictate or we pass through what is standard, what is acceptable, which we are going to implement. Therefore, we are unique, and it has taken root, and therefore we want to convert all these conditional grants into a form of health insurance scheme for the people the government is supporting, and encourage others to buy that. Our lady from Gavi talked about SDG momentum, whether we are leveraging on that in the country, since we had already formed what we are calling SDG platform, bringing together all the key players in our country in terms of SDGs and in terms of where we are going to take health, what we are going to achieve in 2025, 2030, and that platform is going also to rearrange itself to fit into the declaration by government that we all get engaged with the delivery of universal health coverage to our people. And indeed, you cannot, when you look at them, you have to look at universal health coverage, you have to look at SDGs. There's a lot within SDGs which can drive that. And therefore, we have already started the engagement, and we are at advanced stage to be able to bring all key players onto the table. Sustainability becomes very key, both for SDGs and also for universal health coverage. And therefore, as a government, with that realization, we are aligning all our resources within government budgeting system to support a sustainable attainment of universal health coverage. No looking back. So first, government, second, partners. And that is what we are doing.
Thank you, Honorable Minister. Last question for Dr. Musa about the community monitoring and ensuring that no one is left behind.
Thank you. I want to start by thanking those colleagues and friends who raised questions, very insightful questions. So on the community, role of community, I just shared two stories. One is just building on the Honorable Minister from Kenya who just mentioned about the Citizens Platform. As one of the tools that you can often use to really mobilize communities' engagement, communities' participation in kind of realizing the SDGs so that no one leave behind. So last 6th of this month, we in Bangladesh, we kind of working together with a number of NGO and government and other partners to really hold a kind of citizens platform meeting. We worked hard for several weeks and we kind of convened together as a team. And thousands of community people came in, raised their issues, but still we are not sure that all of the people who really needed to be there were there. And so that leads to the second story, where I have my colleague Dr. Afsana here. She and I were kind of a couple of months ago visiting a kind of a refugee camp. And over there, where we are setting up all the systems, we are surprisingly discovering those who needed services more, those whose voices need to come more. They were kind of hiding themselves in the corner of the houses, in the darkness, and especially women. And getting them out of that place to make sure that their voices are there to inform service providers' decisions is one of the hardest jobs. So unless we really go beyond the platforms, beyond the scorecards, beyond the mechanisms to make sure that's happened, it's very difficult. One other thing is just to say that this relationship between universal health coverage and SDGs, I want to emphasize, SDGs are not one thing. It's not just SDG 3. It's about SDGs are together, they're interrelated. And unless we really make sure that they work together, we'll continue to think that possibly universal health coverage is a means to an end. It's not, it's both. It's the means to an end, where SDGs is the end, but SDGs also feed back to the health that we define as health as a condition of complete mental, physical, social, and spiritual well-being. And towards that, we need to work together. Thank you.
Thank you, Dr. Musa. Thank you. And I didn't realize that 1 hour could pass so fast. So we're already at the end of our session. I would like to thank very much all our panelists, but I would like to make some few comments about what you all said. First, as you so rightly said, there are so many pieces of the puzzle. All sectors need to come together to be able to achieve this universal health coverage. But ultimately, the end of this, the whole end is being able to put people first. People first, people at the center of everything that we do, and plan for it, not for now, not for the immediate future, but also for the long term. That was well captured. I would like to crystallize some few points. So to achieve this universal health coverage, it's not just the money, it's also a lot of better coordination, better collaboration, better communication, better alignment with all different sectors. It's being able to build a resilient health system that's very adaptive, and that we need to understand it, that's sustainable, and that's also very efficient, as it was so rightly pointed out. So without taking too much of the time, I wanted to understand why people reacted in the front row when Minister Lam said that the total fertility rate was 1.2. There was some reaction in the assistance, but we will continue that during the break or after the session. That said, thank you very much. Thank you to the government of Japan for hosting us. Thank you to the organizers of the forum, and thank you to you all. Thanks.
All right, thank you all for sharing your experiences with us. We have coffee and tea for you next door in Sunflower, along with the innovation showcase. Please be back here at 4 o'clock. We have 2 more great panels for you this afternoon.